We often hear that in the headlines in the news that there is a suspect case or a patient being monitored for Ebola. The only time that that would really apply would be if the person actually was classified as medium or high risk, necessitating a specimen to be submitted to the CDC for testing. So in all of the cases that we had so far in Oklahoma, none of these were considered suspect patients because we have had no patients meet the criteria for testing for Ebola virus disease. In the event that there would be a case identified in Oklahoma, we would put into place many of the same procedures that you've heard have taken place in Dallas County around that case, where we would rapidly identify close contacts to the case and then implement quarantine and monitoring. Hopefully, we would be able to primarily do that on a voluntary basis and work closely with those persons to ensure their safety and security throughout that process. So at that point, I would like to open it up for any questions. Again, our main objective in having this media roundtable was to familiarize you with what our public health processes and procedures have been up to this date, to enhance our preparedness and response around Ebola, what is happening almost every day now in many healthcare facilities across the state as they do their best to heighten their detection and surveillance for possible Ebola virus disease. And in the event that we may have a true case of Ebola in Oklahoma, what sort of things we would do to protect the public's health.
Dr. Bradley, how contagious is Ebola in perspective to the flu or HIV, measles, stuff like that? To put it into perspective for people that are freaking out over flu-like symptoms, for example.
Right. Even though you hear the term flu-like symptoms primarily pertains to a person having a fever, body aches, joints, headache, maybe a sore throat. Flu-like symptoms can be found as signs and symptoms of a number of infectious diseases, and so we shouldn't confuse influenza with Ebola. They are quite different. Influenza is a much more contagious disease. It's a respiratory disease, and so one that is spread when through respiratory droplets, when people cough or laugh or sneeze, and those droplets can spread several feet away from a person or land on inanimate objects, and if people touch that and then touch their eyes or nose or mouth, that they could become sick. That is not the case with Ebola. Ebola is not that contagious. It is more like a bloodborne pathogen, like our viral hepatitis B or C or HIV, requiring almost direct contact with the blood and bodily fluids or items that are freshly contaminated with the blood or bodily fluids for a person to be at risk of exposure to the virus. And primarily that happens in a healthcare setting where we have healthcare workers caring for patients. We've certainly seen that in our humanitarian physicians and nurses who've been over in Liberia, Sierra Leone, caring for numerous patients with Ebola virus, have an accidental exposure and then contract the disease. Or family members who are in very close contact with someone who has the disease. Another very important point with Ebola is people are only contagious when they are sick with symptoms of the disease, and actually a couple of days into their illness, because they are not contagious before they have fever or other symptoms of the disease. And that's very important. And in contrast to influenza, where in influenza a person can start to shed the virus up to 24 hours before they're actually ill.
You mentioned people who are in isolation, and I think all of us have heard from different hospitals of people being put in isolation. We're all, I think, very familiar with the protocols in place. But could you explain what you're talking about when we're going to be notified, and maybe when we should start being concerned about reporting versus what in isolation means, and what the difference is, and when that becomes not a big deal versus maybe something to talk about?
Well, just to be extra cautious during the screening process, the healthcare facilities will immediately put that person into an isolation room or area when they have some of those early criteria of being in a country that's affected with the virus or reporting symptoms of illness that might be consistent with Ebola. So they're going to be put into isolation very early into the process, even before the healthcare workers have a lot of time to ask them more questions about their potential exposures, and also to do more examination of the patient and do some other preliminary diagnostic tests to rule out other more likely causes of illness. A large proportion of persons who travel to these African affected countries and come back with fever and headache and body weakness and maybe even some bleeding problems have malaria as a more likely cause than Ebola. And so it's important that the patient be evaluated for a number of different things that might be causing their signs and symptoms.
The patient that went to Deaconess that caused kind of the scare and the protocols to go into place, that person recently traveled to one of the affected countries, and we're talking about a man, a woman, child, approximate age. What do you know about that patient?
Well, I can't speak to specifics, but I can tell you that the travel exposure history was not consistent with what we would classify as a suspected case. So this is really a time, if you will, for everyone to learn their African geography. And we are planning to disseminate these posters out to more of our medical care clinics, so these will be readily available so that persons can see exactly which countries are of a concern and where the Ebola epidemic is spreading still at very high rates.
So you're not concerned with the event in Dallas and anyone who may have come in contact in the Dallas area?
All of the persons that would be at risk of being exposed to Ebola from the case in Dallas were rapidly identified by the public health officials and epidemiologists in Dallas County and with the Texas Department of State Health Services. They've been under quarantine and being monitored for a number of days now, but they will be monitored for the full incubation period of the disease, which is 21 days. So they're still in the midst of that.
And what lessons have you, I guess, the State Department of Health across the country learned from that event where that person was originally sent home and others were potentially affected by it, and then he came back to the hospital? You want to talk about that?
Yeah, I think one of the biggest wake-up calls for everyone is that the need to have the very sensitive screening protocols, and that's largely what you're seeing now. It almost seems like recently there's been a pretty large uptick of the number of patients we're hearing about that are being screened to determine if they may be an Ebola suspect patient, and that's largely because of what happened in Dallas. Nobody wants that to happen here, that a patient would be overlooked, and so our healthcare providers are doing an outstanding job in Oklahoma, very much aware of the need to have those standard triage and screening protocols in place. So if they hear of a possible travel history to somewhere in Africa and are having fever or other symptoms of illness that could be consistent with Ebola, they're appropriately putting them into isolation and beginning to ask those questions. But just because they are doing their job in doing that triage and screening process, that should not be construed as meaning that we're having an increased risk of Ebola. It just means that we're more on alert, if you will, and doing a better job of screening to detect any cases should they occur here in Oklahoma.
I know part of that protocol is to notify the health department that there's a possible exposure or a risk. What was the call that you guys got last night? What were the details of what they said that kind of sparked that fear?
Thank you for asking that. That's a very important part of our protocol. that as soon as they think that a patient may have, be a suspect for Ebola virus disease, that they contact our epidemiologist on call, which they're available on a 24/7 basis, and then they will consult with our epidemiologist, and we'll use the same questions that are in the screening algorithm that you have in your packet, and go through those questions together and collect more information, including some test results from laboratory tests and other clinical features, to make that decision of if they're no risk, low risk, medium risk, or high risk, and whether there's sufficient information to classify them as a suspect case requiring testing.
So what was the call that you got last night, just the gist of it, just, hey, we think we've got somebody, or what was the call that came in?
Well, we received more than one call actually yesterday, and that's something that is ongoing, and that's the way public health should be working, in that anytime we have a patient who meets those initial criteria for a possible case triggering the use of the screening tool, that it's at that point that they contact the epidemiologist to discuss further and to consult and work with us through that screening protocol.
So you had multiple calls from different facilities yesterday?
There were more than one inquiries, and we cover the whole state,
But
so.
more than one just from that facility, or multiple
No,
facilities?
from different facilities. More than one call involving different facilities.
Are we talking two, or are we talking dozens, or are we talking?
I think we had 3, 4. Yeah, Dr. Lori Smithy is the director of our acute disease service. She oversees the epidemiologists who conduct those investigations and assist with those consultations. So she indicated there were 4 yesterday in total.
About
Can you
patients or
elaborate?
just like general, like, information about Ebola?
No, 4 patients. 4 patients that the medical facility saw a possibility that they could be a suspect patient, put them into an isolation room, and implemented the screening protocol and consulted with the health department.
And
Can
you said
elaborate
if
where
we're,
those facilities were?
I don't think that we would share that information. I don't think that's important. I think what is important is for everybody to realize that even though there may be one high-profile case that becomes more aware or recognized by the media, that we consider this to be more of our day-to-day business of conducting public health investigations to control and prevent the spread of Ebola.
you were saying we shouldn't be hearing about people who are going through the screening process. We should only be hearing about those who have met these criteria and are in need of a blood test. So any screening, like you said, the 3, 4 calls that you got yesterday isn't information that you will be giving us on a regular basis.
Correct. There really is no reason to alert the public about those that are just went through the initial screening process and then were screened out as being a suspected case. I think what's more important, if we focus on just sharing information about a true suspected case of Ebola, and then share that information very openly and keep the public aware of where we are in the public health investigation process, and let them know actually if a suspected patient is present and being tested, and then the outcome of the test, of course.